I got this title, I thought that I can talk about whatever I want. So I thought that I will talk about the molecular classification of cancer, especially that you mentioned the tumor agnostic therapies, and I try to put into historical perspective of this, and I try not to predict the future. So cancer diagnostics started at macroscopy. It was Morgagni who described it. And then next step was the histopathological characterization of tumors, which is today the diagnosis of cancer. So it's not a clinical diagnosis, but you need the histopathological diagnosis. That was the cellular pathology. So based on cells, we can classify cancers into pathologists believe important subclasses. And then comes the 20th century technologies, how we started to differentiate these histopathological forms into subclasses further. And then came the surprise, big surprise, that DNA alterations define the various tumors. So now we use these technologies to identify the basic mutations or genetic alterations like gene amplifications for cancer treatment. But then came the next generation sequencing where maybe not the whole genome, sometimes the whole genome, but at least the important part of genome is sequenced, and we are getting all those data, all those genetic alterations, and now pathologists, and especially the molecular pathologists or biologists, don't know what is the significance of all of those genetic alterations. But the life started to change. So beside the histological classification of cancer, we start to see the molecular subclasses. Like in the case of breast cancer, we have at least 7 or 8 variants histologically, but for clinicians, nothing. The most important is the hormone receptor positive forms, hormone receptor positive and HER amplified, then the HER2 amplified, and then the triple negatives. And they don't care about the pathologists' sub-definitions, those little alterations like medullary cancer and so on. They just focus on their attention because that has the therapeutic consequence. They know what type of treatment they can use. So that was breast cancer in 99 something. But before that, hematologists already started this type of game. But then came the lung cancer, where the pathologists know that there are 3 different histological versions, and then they start to do the molecular, first the differentiation, because it was important to use various chemotherapeutic agents in those variants. But then came the molecular classification of cancer. In case of adenocarcinoma, it's nice. It gives you rationale for molecular target therapies, like in case of KRAS, now the KRAS inhibitor started to appear, but for a long time it was the resistance population. Then comes the EGFR mutant patients who were treated by EGFR inhibitors, and come the rarer and rarer variants like ALK and all these stuffs. And then we started to understand that there are even resistant mutations, but what I want to show that beside the most frequent mutant versions, we start to focus our attention to the very rare genetic alterations like the translocation cancers, the ALK and the ROS and the RET and NTRK. And so all these genetic variants are important, but only in case of adenocarcinoma. So not everywhere, but in here. Because in squamous cancer, we have different molecular alterations. So here, the histological subtype defines the molecular pattern, and these molecular patterns are unique for the pathological variants. So we can say that doesn't matter what is the molecular background. The two are connected. And this is the same true for the neuroendocrine or small cell lung cancer, where the genetic profile is unique, specific for the small cell lung cancer, and you can't find it in the other type of lung cancers. So I was very happy that, yes, this is the life. So you have the rationale of histological subtyping, and then you can connect with molecular subtypes. And you can't say that molecular subtypes counts only. Okay, but here is the colorectal cancer. In case of colorectal cancer, basic genetic features are the mismatch repair system alterations, or the RAS mutation, and BRAF mutations. These are the three major genetic subclasses which are completely independent, or almost completely independent from the pathological subclassifications. So in this case, the only important information from pathologists is needed: colorectal cancer or not, and then that's it. Then the molecular subtypes will define the therapy. Now, there were little papers, and not so little ones, that there are rare but important targetable alterations even in colorectal cancer, which can be important clinically in those KRAS and BRAF non-mutant 50% of cases. And then comes the HER2, which I will come back to this at the end of the whole story. And I think now I tried to put together whether this type of things, that histopathology and molecular classification, collide or work together. In case of prostate cancer, we have this WHO histopathological classification of prostate cancer, which for pathologists is a long list, but nobody cares about it. The only question, what about the androgen receptor function? It is mutated or amplified, because then you can't use the anti-androgen therapies. Or there are other alterations like TMB high, so the high mutation rate, or there are the HRD, the homolog recombinant mutated ones, which are the BSC ones. So it seems again here that the molecular subtyping is much more important. What about the pancreatic cancer? Here is the long list of 30 different variants of pancreatic cancer, and clinically you can't use it because all of them very resistant to chemo, and you don't have good molecular targets, because this is the tumor which is KRAS mutant. And if somebody don't come up with a good KRAS inhibitor, and especially that here not the C but the D or V version of KRAS mutants here, doesn't matter what is the molecular background behind KRAS. KRAS lead the game. The only thing which might help is the homolog recombinant alteration, which is a quite significant proportion of even the pancreatic cancers. And only in the KRAS wild type 10% counts all those other genetic alterations which might be targetable and might be clinically useful. And the same situation here for urinary bladder tumors. We have all this nice long list of pathological subtypes, histopathological subtypes. Oops, I don't want to go to this. But the molecular classification start to drive even the treatment of bladder cancer. You see that the HER2 amplified versions, FGFR3 mutation, even not KRAS but HRAS will count. So it seems again that pathologists work for long to subclassify histopathologically the tumor, and then the molecular profile comes better. And melanoma is a good example where pathologists don't have a problem because this is melanoma, that's it. And then we have all those different molecular subtypes, which the BRAF mutation is the most frequent, NRAS or KIT, and the rarer ones where you can find some good molecular targets. Unfortunately, only a few can be used. And the same story, thyroid cancer, 4 different histological types, and interestingly, you can connect, somehow like in case of lung cancer, histological subtype to a molecular subtype. So it seems that cancer use different techniques. It can be pathologically driven molecular business and molecularly driven pathological business, which is can be very confusing. And then I realized that tumor-agnostic therapies appeared. And it turned out that microsatellite instability is a common genetic alteration in various different cancers. And God bless those ones who run the trial for tumor-agnostic way for microsatellite instability cancers, which turned out that the immune therapy and immune checkpoint inhibitors are working very well in microsatellite instable tumor. And that almost the same is true for the tumor mutation burden high tumors. So you don't need, you need only the malignant or benign, doesn't matter what type of pathological subtypes. These are the therapy determining important predictive markers. And of course, the fusion gene story is very similar to this, although I'm still a little bit pessimistic because not enough pathologically different histotypes have been used, and in the background I know that there are a lot of molecular differences between different tumors, so maybe not always they're a good target because some other mechanisms, but at least in the registry these are the targets, and the newest one is NRG1. NRG1 fusion is a very, very rare alteration, even rarer than the anti-RK, but NRG1 is a ligand for HER2, HER3. And they designed an antibody which has a bispecificity for this, and in the trial there were 10 different tumor types, at least in lung cancer and pancreatic cancer. This drug worked very well. So I'm sure that this list will go further. BRAF mutant cancer is somehow doesn't fit well into this story because not all BRAF mutant tumors respond very well to the BRAF inhibitor therapies. The best example is colorectal cancer, where we badly would need this, but it doesn't work there because other molecular mechanisms do. And the last story is the HER2. HER2 amplification or mutation is very frequent in major cancer types and rarely but occurs in any cancer type. And our diagnostics was based on immunohistochemistry, and the pathologists always teach the young guys that you need a 3+ strong expression, 2+, then you have to do the FISH, and then 1+, forget it. And this whole world changed completely. Now we are hunting for weak expressor tumors or the 2+, and any kind of tumor, you can do these diagnostics. And it seems that it helps because this HER2 drugs, antibody drug conjugates or new versions of drugs can be efficient in those tumors. So again, tumor agnostic molecular alteration will drive the whole story. So I was a little bit sad because I remember 20 years ago when molecular biologists, geneticists came that only the molecular profiles is important and doesn't matter what type of tumor. I thought I will kill myself because it's stupid. But it seems that slowly this changing. And then I started to think back, what was the traditional treatment of cancer? Tumor agnostic. Irradiation, big hammer, or other chemotherapy, big hammer, not much variations in different tumors. Surgery, tumor agnostic, totally tumor agnostic. So maybe the life will change to complete tumor agnostic ones, but I'm joking, of course, because I think the combination of the two will be important, because we only analyzed, let's say, 10, 15 different types of human cancers, but we have 200 different types of human cancers, and very dangerous to predict the future just based on the story on 10 different tumors, to predict what will be the future for the 200 others. But most probably we have a pathological classification, and at least we have to put there the molecular subclassification to that tumor type. And if we are lucky, there will be many, many tumor agnostic indications, but we shall see the future. I don't want to predict it. Thank you very much. That was what I wanted to say.
Thank you so much.